Everybody, this is Erica Mello and Susan Clinton, and welcome to episode number 210. 210, baby. We're chugging along. So this episode is about not a specific patient per se, but I'm going to thread a patient scenario through it, but it's about holes in an exercise program. And so both Susan and I do we do some consults with other physical therapists on patients. And if somebody were to hand us a patient scenario, what they've done, their treatment and their exercise, I want to see where there are holes in an exercise program. And that's what this episode is about. And it's going to be dependent on the driver. So we hope you enjoy it. And, this is going to air. We're recording this at the end of March. This will air in May. We hope you all have enjoyed a lovely spring, and welcome to all the new listeners. For those of you who don't know, we are on YouTube now. We've been on YouTube for a while, but it was mostly audio. Now we are on video as well. So you can see our faces, and feel free to comment on anything that you've seen. And if you have any questions, it's a great way to reach us. We do actually get the notifications now. So, and for those of you who are new and want to listen to old podcasts and have questions about certain diagnoses, just go to our website at toughtotreat.com and type in the search bar, low back pain, knee pain, whatever, pelvic girdle pain, and there's be a host of episodes that come up with those keywords in there. So thank you again to all the listeners, and hope you enjoy the episode. Hey everybody, this is Erica Mello with my lovely co-host, Susan Clinton. How are you, Susan?
I am good. Looking forward to what we have in store for today.
This is episode 210, and it's about holes in an exercise program. But let me give you, excuse me, just a little bit of background. I have a patient I've been treating on and off, excuse me, oh my Lord, on and off for probably, let's see, pre-pandemic, 2019, maybe 5 years, but very more off than on, like once every month. Got a frog in my throat, Susan, hold on. Okay. And she came in to see me initially with issues with her shoulder, left shoulder pain. And her driver was her thorax, her upper thorax, and her glenohumeral joint. And so she also had issues with her right side of her pelvic girdle pain, right side of her pelvis. And I gave her an exercise program geared towards her thorax. And then the pandemic hit, and we were virtual, and so here we are now, 4 years later, seeing on and off once a month, very active individual, like an ultra, runner, like not like professional athlete, but almost at that level. And she was doing really well. So a lot of her issues in her left shoulder and her right SI joint were being driven from the thorax, because she felt it a lot when she was driving. And where do the hands go, right? Susan on the steering wheel. And, it was really how she was translating, and loss of control with the wheel while she was driving. So that resolved. In her history, she has an ACL surgery on one knee and an ACL on the other knee. Okay, probably 15 years maybe prior. No other, those are the two surgical procedures she's had. No other major injury history except that left shoulder. And for those of you who are going to ask, she did have thoracic outlet type symptoms. She felt like, running water coming down her arm. She felt coldness as well in that left shoulder into the arm. And I don't even remember if I did any of the thoracic outlet tests on her. I was able to reproduce her symptoms by just sticking my index finger and my middle finger right into her left armpit, and it just reproduced everything. That was in 2019. So having said that, I gave her an exercise program geared towards her thorax. Okay. And so now she's coming back in to see me with, because she's racing a lot more now and she wants to be more preventative. She's coming in to see me for, on and off knee issues, on and off foot issues, but more off than on. But because she has a goal that she wants to go towards athletically, she's trying to be very proactive. And so I took a look at her exercise program, because I can do the release in the office, but she's not local. So I will do that, but I wanted to look at her whole program. So for initially, I'm just going to go through this quickly, Susan, and then I'll ask your opinion on a couple things. So with the thorax, the main strength holes that I see with people who have thoracic drivers, strength holes would be triceps, abdominals, and anterior deltoid. So if an exercise program does not include any of those, even if the person has right hip pain and their drivers, their thorax, you must address those three muscles. That's my opinion. Triceps, abdominals, and deltoid. Okay. Okay, I'm going to move on. And then we're going to go to the knee. So the similar thing with the knee. So what I tend to see is I don't generally, we haven't done a ton on knee pain. We did an episode, I think early on, Susan, like our episode number 4 on the golfer I saw who had chronic right knee pain, and he was loading that right side. That's going to be very relevant to our last episode we did on center of mass. He was loading his symptomatic side. They were working his quad. That was the wrong muscle group, right? So when I see patients with knee issues right now, more often than not, there is a foot component. And so the patients that I see who come from elsewhere, they're going through the traditional quad strengthening, hamstring strengthening, glute strengthening for their knee pain, and whether their knee is their driver or not. And so what I tend to see that the knee is most often not the primary driver. It's either a foot with it together or something else. And so what I tend to see in patients who have those issues, I tend to see overactive adductors, overactive hamstring, medial hamstring, overactive gastroc. They tend to cross the knee. And so I don't generally give out a ton of exercise like specific to the knee, because what I've seen more often than not is an overactivity. And then when I release those muscle groups, I'll look. And more often than not, it's a deficit lower down in the foot. I'm going to do one more and then I'll get your thoughts. With the foot, because this patient was coming in to see me, many years later with the knee and the foot. So with the foot, the main issues I tend to see, the overactivity, are posterior tibialis, medial or lateral gastroc. And sometimes there's some compression in like the calcaneal cuboid joint. So I'll, in the bottom of the foot where deep intrinsics are. But unlike the knee, the foot needs to get trained. And there's a lot of loss of control once you quote unquote release, however you do that, release those muscles, and then you'll notice a loss of control, where I don't generally see that so much in the knee. Do you have any thoughts, Susan, or should I keep going?
You can keep going for right now.
Okay. Have some water. Okay, so she came in to see me again. I said, I need to look at your program. And I looked at it and I noticed, so when anybody has a thoracic driver, which she did, and she was a runner as well, you can't just give them, as I mentioned before, anterior deltoid, triceps, abdominals. You can challenge those in many activities, squats, lunges, split squats. So I said, I looked at her program. I'm like, where are your lunges? Where are the split squats? More for my mind than hers, because it had been a period of time where I haven't seen her. And she's like, I'm afraid to do them. And I was like, excuse me, why are you afraid to do them? And we did an episode, Susan, a while back on fear-based movement patterns. If no one has listened to it, I would highly recommend that you do. So I was like, well, you're a runner, you run multiple miles weekly, and you are afraid to do a lunge. Okay, not a backwards lunge, but a forwards lunge. And ironically, if someone came in to see me as a runner, the forward lunge was the first thing I would assess. There was a mental block, and I'm using that with my hands here, a mental block. Oh, I don't do lunges. I'm like, if I looked at your program right now as an outside therapist coming in, I would be like, where the heck, what you need to do? You need to do something like that. And she's like, I'm afraid. And I was like, okay, this is a problem, right? So, do you want to chime in here?
I have a couple of questions now.
Yeah.
Okay, so she has a thoracic driver.
Yes.
And thoracic drivers need to do lunges and split squats. I think people are going to be missing that connection there.
Okay, so for me, you need to train the thorax in sagittal, okay? sagittal plane as well as transverse and frontal plane. And so with the lunges, it's a sagittal plane. That's an easy act. That is an easy exercise for the thorax to do. I always tell patients to wrap a band around their forearms and just hold. I would be remiss if I did not include that in someone's program because they need to go upright. And so the thorax is the split squat and the lunge is a very easy exercise to do with someone who has only a thoracic driver, not a foot or a knee issue. Does that answer the
Yeah,
question?
because I think when you were talking about it, people weren't making the connection like, why am I asking about lunges and split squats when somebody has a stiff thorax, and bringing in the whole TheraBand across the wrists or putting the hands on the wall or doing those things actually involves the thorax so that, they're not being pulled in one direction or the other, side to side, or being held stiff on one side, making it impossible for them to move to the other side. So, and I just wanted to be sure that everybody kind of got that.
Thank you. And
Okay.
right, I appreciate that. So
Clarification.
yeah, and so I usually start people on their back with like TheraBand arm exercises like chest press, skull crushers for triceps and overhead flexion. That gets triceps and anterior deltoid, those strength holds I mentioned earlier. But I will move them up. And so you need to go into rotation, but but I would do the neutral thorax first. So you need to, just because someone is a thoracic driver or a glenohumeral driver or a neck driver doesn't mean you're keeping them on their back doing stuff or sitting. You need to get them upright. As long as they
Mhm.
don't have a foot or a knee problem, I think they need to go through life, right, Susan? They need to stand and move. And so that is why I gave those to her. She could do a split squat. She could do a backwards lunge. She could not or would not do a forward lunge.
So she's coming to you because she's worried about her foot and her knee.
Currently, correct.
Right. And so that's why she's not doing the lunges and the split squat, is because she's worried about, does it bother her to do? Is it
Yeah,
painful?
yeah, she's never done them. And she does have some pain when she does them. But what I find interesting is that she can run a lot of miles
Mhm.
and have zero knee pain. And so there's something inherent in how she postures herself when she goes into that exercise that requires thought. Whereas when
Mhm.
they're running, you're just sort of like on autopilot, not autopilot, but it's more of a offload, offload, offload. And
Right,
so,
automatic movement.
right. And so this, that if I looked at her program, that's a huge hole, right? Same with, early on, she had stopped doing the abdominal exercises. And I said to her, that's a huge hole in your program. For people who have a thoracic driver, abdominals are a significant strength hole in my patient population. If you do not do abdominals, whether it's a plank or a forearm plank or on the wall or however you do them, I don't think that you will get where you need to go. I mean, if their goal is just to go up and down stairs and they're 85, okay, but I don't see that population much anymore. Okay. So her goals were very high achieving. And so I think a lot of people have these fear-based patterns. I have a lot of patients who do. And she's had 2 surgeries, ACL surgeries, one on each side. And she has no problem doing it on her other side, her other ACL operated side. It's just this one side. And yes, she does have the overactivity that I mentioned, overactive hamstrings, adductors, etc. But because she has a very lofty training goal, like to make a national team, I said to her, I would absolutely be totally remiss if I didn't get you to do lunges. I'm sorry, you have to do them. I didn't say it that way, but it's like we need to get you to do them. Normally I'd be like, okay, we'll move on and do something else if that's like, but this girl has to do these in order to get where she needs to go. Right. So do you want me to keep going?
I just wanted to bring up one other thing that I think is important here, because when you're talking about overactive adductors, hamstrings, and gastrocs, you've got somebody who doesn't want to do a lunge. So when they go into a forward lunge, they're probably bracing a lot of things one of the things that, and I know you talk about the foot component with the knee, one of the things that I see a lot of with people is low back hip drivers with the knee.
Oh,
Part of the reason that they won't go into a lunge is because they can't allow themselves to flex down deep enough in their hip joint. Their hip joints being held in an anterior kind of posturing femoral, anterior glide, and they
mhm.
can't go down deep enough to, so they end up they end up loading straight down rather
Mhm.
than getting a hip crease
Yes.
for the
Yeah.
lunge.
Yeah.
So, and when they do that, then their knee goes forward more, and they're really over recruiting quads, and
Yes.
it can be painful. I'm just kind of wondering if you saw anything like that, and of course, it makes them tilt on one side more than the other too.
Yeah, so I didn't see that in the hip, but she had a right pelvic girdle SI joint, symptoms, which are thorax,
Mhm,
which resolved on the thorax. So it could be that she, intuitively didn't want to load that, so she postured her
mhm.
pelvis in a way. I didn't see that, but that I would agree with. That I would agree with, but
Yeah,
I didn't.
if they can approach the lunge and, allow their hip to go down, allow their hip to flex,
Mhm.
then they get more of a rolling in their knee joint rather than a straight down compression.
Right, and
Because
yeah,
many of them tend to lean too far forward, and then they're just trying to go straight down on it. Same in a split squat.
right,
If you can
right.
just kind of allow that hip crease to occur, you'll also see it in a regular squat with them because they won't go down. They won't let their, they can't reach their hips posterior,
Yeah,
to go into
right.
a nice hip crease.
Yeah.
They stay too far forward and it hurts over
Yeah.
time.
Yeah, and so it's interesting you say that because when I watched her squat and I'll kneel, it's her left side. So I was kneeling on her the left side and I'll just put my hands on the tib femoral joint and the superior tib fib and I'll just I'll close my eyes and I'll just, we all know the mechanics of the knee and the screw home mechanism. And I'm looking for that terminal knee extension and I'm looking to feel if there's any joint line compression. And that just takes practice and putting your hands on many knees over the years and comparing it to the other side. I often see, a lot of, some joint line compression, mostly coming from overactivity, right? But she was fine with the squat, like in terms of able to do it and, able to sort of, not have any symptoms. So then I had her do a body twist. And so I just had her basically keep her feet in one place and just basically do a body twist, just like, you're turning around, looking at somebody, same
Mhm,
thing. Her mechanics on her left side they were horrible. I mean, she had zero mobility in the knee and the superior tib fib and the tib fem joint, zero. And is that relevant? I believe so. I didn't want to like make it a big deal for her because she's doing really, really well. So I had her do a couple of other movements that would also sort of test that rotation. I had her like just do a basic squat with rotation, not even doing like a standing rotation, just squat and rotate. She didn't have any problems with that. And so what the reason why I wanted to mention her is because the training program for somebody like her or an exercise program for somebody like her is going to change. Excuse me, is going to look different and change for somebody else who doesn't have those high level goals, right? Would you agree?
mhm,
Okay. And because I'm a nitpicker and because I like to problem solve, I just didn't understand why the lunge was not in her in her brain, and she loaded her left, and so she loaded her left side, like she offloaded that painful side in when she went into the split squat as well. So the split squat with the right leg in front is a static maneuver. it's that it's that lifting of that right hip, placing the right foot down and then lunging forward, going into that forward motion that got
mhm.
her. So I said, well, we could start with split squats. You can do many of those, but looking at the whole program in general, you're not going to give somebody 50 million exercises. And seeing the pattern that I do, I see over the years, it's an overactivity. And so for the love of Pete, if people therapists that are listening, I see so many people who what's the word, they come in with knee pain and then their quads are like, they're all working on their quads. 9 times out of 10, those quads are overworked and there's a muscle imbalance somewhere else. And I know you've seen this too. It's just not the quads,
Mhm.
people. It's just not the quads. And this is what my young golfer I treated the same problem. It made him worse. And so I don't think that, because we don't do a lot on the knee on this on the podcast, but I thought that now, because people are out more running and et cetera, it's just that, just because someone has knee pain doesn't mean that that their quads need strengthening. It's usually the opposite. And so, but with her, clearly they didn't need strengthening. She just needed to be able to do that movement, to have an overall program. Because I told her, I said, I would be remiss if I did not get you to do this. So my question to you, and I have a few thoughts, but I'm curious. We're going to get her to do this, bearing in mind she's a thoracic driver. Okay. And she has a secondary foot thing that comes and goes, but we've got that under control. So knowing what we know about the thorax and the strength holes, and knowing what her fear-based pattern is, how are we going to get her to do that forward lunge without being afraid?
Yeah, there's several things that come to mind. If you want to go the idea of like if we can get the foot feeling good before we go the other direction, I would have her do it on the left first,
Yeah.
on the right first,
Yes.
because
I
that
mean,
gives
on
her
the other
left
side.
foot control because her left foot has to control that
Yeah.
in that position. But start where they can get comfortable. And if she's overloading on or offloading on the left side, we really want her over on that left side a little bit. So it's really simple to work with a stick and to hold a stick in midline, uh, right in between, kind of
Yep.
almost like a rudder.
Yep.
So as you lunge, the stick goes forward and you come back, just to
Love it.
give them that sense, but to also help them realize how far off they're going to the other side. Because if she's like overworking her adductors as a protective mechanism, it's going to pull her off at her pelvis.
Right.
Mhm.
Right.
So, or if they don't respond well to a stick, like if somebody has balance problems, I would do something on both sides with their hands on the chairs. We talked about this in the last
Yeah.
podcast.
Last one. Yeah.
But for somebody like her, she should be able to do this with, just one, like I just a tell, a
Great
telescope
idea.
hiking stick works well,
Yep.
and just being able to grab it. If she's really going too far over to the right, I would actually have her put that stick on the left side with her left hand.
Ah, okay. Great
This
idea.
is a little neuro trick
Mm.
that when people are constantly kind of pushing off onto the other side, to the stronger side, to the more sound side, whatever it is, sometimes when we just put something over on that side, they'll shift back. And I
Mm.
don't even tell them, "Wow, just say, stick over here. Let's give it a
Mm.
try. Put your hand on this chair right here next to you. Let's give it a try. Let's see which one works the best."
Mhm.
And then I would probably play some target practice with her too.
What do you mean?
As far as, can you put your foot out and lunge a little bit?
Ah,
Can you
got
put
it.
your, how far can you go? And kind of thinking about like, when you lunge, can you sink here, more into the hip if that's an issue
Yeah.
for her? I don't know if it was or not, but for somebody, when they're shifting over, that pelvis tends to go up on the side that they're shifting away from. It's like,
Mhm.
can you keep your headlights on the highway here in front of you? And as you go down, can you come down more this way on your back leg, so that you're actually, not so much more on your back leg, but that you're actually driving the hip joint down versus trying to lean forward over the knee joint.
Mhm. Mhm.
So kind of like just a
Doing. Yeah.
yeah. So like just I want you to come down more here.
Yeah.
Like I still
Yeah.
want you to lunge forward. I still want you to put your foot out. I want you to go, but I want you to come forward. And then the big key for me with people with lunges is then once you're there, I want you to push yourself back up. I don't want you to pull yourself back up by the other leg. I want you to develop the power to push through your left foot,
You're
get
leading
yourself
with.
back up.
Right. Right. The
And they
leg and
won't be able to do it if they don't have a hip crease because they won't be in a position for their glute to help.
fire. Right.
Mhm.
Right. Right. I
Which is
like
why
what
their hamstrings are over exercising.
that's right. That's right. That's exactly right. Um, I like the dowel or the stick.
Mhm.
I'm thinking of, right, actually you could do it both, right, left,
Yeah.
middle.
See what makes it work. Who
Yep,
knows what it's gonna be.
yep, yep. And what I also, I mean, I have access to Pilates, but
But it also brings up when you have it in the front and the middle, it brings the whole, like, they have to recruit around their thorax a little bit differently.
yes,
And just
that's
letting the thorax be wherever it is, right?
yeah,
It has to, like,
yes,
oh, I have to pay attention, I have to be here. I have to control the stick,
that's a
so that kind of like hooks that all up a little bit.
yes, that's a great idea. Because she was a thoracic driver and that was under control, just because, it's under control, if you introduce a new exercise, you just want to make sure that that thorax stays under control. And the lunge is a very easy exercise for the thorax. So what I did with her as well, taking a cue from what you were saying with regards to using an object, I held out something like a piece of paper with large words on it. She didn't have any neck issues, no sort of
Mhm.
A's, VOR stuff. But I think, we could do a whole episode on the VOR and the vestibulo-ocular reflex. I had her read a piece of paper, like I was, I don't know, maybe a foot from her, and I had her read while she was doing the lunge, not with the painful side first, with the non-painful side first. And then I had her switch over and I just had her do like similar to what you were saying, very just small. Even if you go down, like you bend the knee 5 degrees while she was reading, so her gaze would be fixated on that. And that tended to stabilize her. It also took her mind off of her knee, which is the only reason really
Mhm.
why I did it. But I was like, I think she, and a lot of people don't use their head or neck. We've talked about this a bazillion times. I think we all could benefit from a little bit of, gaze stabilization training, because we're looking at computers all day. And so that helped her a lot. What do you think about, uh, I like the stick. I have not used that, so I will. What do you think about having her move the stick in, like, it'll challenge the rotational? That will be a higher exercise for the thorax
Yeah.
as well.
Yeah.
And rotational control, plant it here. Like plant it
Mhm.
like the clock, the 9, the 10, the 11 in front of you while you're lunging. You're going to have to stay, in that straight plane with the knee, but your thorax is way challenged in
Mhm.
that you're planting it, like right? You're planting it,
Yeah.
right?
So lunge and put the stick on 7, lunge and put the stick on 10,
Yes.
like that. And, that she'll have to work up to that. I like them being able to keep the stick in one place, and like the bottom of the stick in one place,
Hmm.
but they can move the top of it around
Oh,
as
yes,
they're
like
going. So
stirring.
you can do it, and then they can actually make it more dynamic. So you can do it any way you want to do it. Um, for somebody like her, once she gets that, then I would have her lunge onto a Bosa ball so that
Yeah,
she has to control it,
yeah,
as well, because this is somebody who's going to be running miles and miles and miles. Um, we want them to be able to have the perturbation,
yeah.
in a lunge, especially if they're going downhill or uphill, or up and down or
Mhm.
around or a switchback.
Running, yep.
You want to be able to train that variability. So I would say that once you really get it going, that they should be doing lunges on and off of a Bosa ball. You can even
Yeah.
do split squats on them.
Yeah, I mean, she was doing this, I mean, the split squats I gave to her early on for in the
Hmm.
thorax, and she didn't have that fear. The lunges, so I had her do backwards lunging and, different movement pattern, different load on the hip, different load in general. And, I've given those often to people who have pain when they have problems lunging. I think hers was more, it may have been a little bit of pain, but I think it was just really more of this fixation that I just like, don't do them, for some reason. And the coach or the running coach absolutely wants her to do them. And I'm like, once again, this whole episode's about holes in the program. That's a huge hole in her program. She's a runner. She needs to be able to do those, right?
Hmm.
And without fear, especially because athletes, I think, can compensate really well until they can't, but they can compensate for long periods. And you can go, how many ever miles you're, let's say 40, 50, 60, 70, 80 miles a week, and you're good with that. But then you bump up because you want to make a team. You go up to 90, 100, and that's a significant challenge to your system. So if I was as an outside therapist looking in at this program and knew nothing about anything else, and I didn't see any kind of progression with that, I would say that's a huge hole. And right, not knowing anything, just looking at it like just a piece of paper, right? That's a huge hole. And so I like the BOSU. I think that's good. I think anything to sort of take her mind, or not, I don't want to say take her mind, but disassociate the movement pattern and change the props or change the environment, I think is a good thing.
Yeah. The other thing they can do if they're super, super afraid is you can always suspend yourself in a, over the bar band, one of those big resistant bands.
Oh, the Franklin bands.
But the bands that you can use, but they're thick. People use them to assist with pull-ups and all kinds of
Oh,
things.
yes.
Right. So you can, flip it over the bar,
Yeah.
like a higher bar, and she can, she can either put her thorax in it and hold on, or she can just hold on to it. But then she can play with it because she has that assistance to let her like play and go forward and come up and play without her whole weight going on and going down. For somebody who needs
Great
more,
idea. Yeah.
those things work really well too. They have to, sometimes the band pulls them off all over the place. So you have to like, kind of like, let's, it's a
But
motor
that's a
control
good thing.
exercise too.
Yeah.
Keep it to where, the band can assist you. It'll
Mhm.
assist on the way down because it won't let them go down so far without pulling.
So the
But
band's
it
gonna be
also,
over them.
yeah, you can hold it or you can put it under your arms
Oh,
and kind
yes,
of hold on this way.
yes.
You can suspend yourself from it pretty easy.
Yeah,
A
yeah,
lot of
yeah.
people, a lot of people
Well,
do that. If you don't want to use a stick and you have a TRX available, have them hold on to the TRX and go down into the lunge.
yeah.
So it's just, just depends on what you have and where their buckle point is or where they're afraid to go to.
Yeah, I
Like
like it.
if they'll
It's
lunge to like 60 degrees and that's all they'll do, well then the goal is going to be, can we get them to like 60, 65, 70, 75 without the fear?
yeah. I like the assisted lunge. I like the with that TheraBands. I do that a
Mm-hmm.
lot. The patient now I'm treating, I'm trying to get him to do, his deficit is on the eccentric of the pull down of the like the pull up, but it's the eccentric lowering. So I have him doing like an assist on the way down. Oh no, assist on the way up and then slowly lowering on the way down. So I
Mm-hmm.
like that. I really like that a lot, especially
Mm-hmm.
for people who have true significant knee pain with that. She doesn't have horrible knee pain with that. A little,
Right.
a little,
But people need to feel safe. And if she's not
right.
feeling safe,
That's right.
she's not going to do the exercise. This is a clear case of somebody who has the ability to do it, but because they don't feel safe, they're not going to do it. She might do, she does a lot of her exercise consistently. She knows the relevance of it, but if they don't feel safe, they don't have all three of those things, people aren't going to do them.
Yeah.
So that's
And
why you needed to sit with her and ask her, why are you not doing them? What's going on here? Because if it's a safety issue or I'm afraid, I don't want to, that's a safety issue. In her brain, we may be thinking, oh, you shouldn't be afraid, you're fine. Well, that doesn't matter what you say to them. It matters what they internalize. And so
right,
if we can
right.
help her feel like, oh, I've got this. This is a way
Mm-hmm.
to do it. I will do this. I don't
Mm-hmm.
feel afraid of this one. Then
Mm-hmm.
they will do it.
Yeah.
Right? If
Yes.
they're afraid, they're not going to do it.
Yeah. I mean, that's right. And I think with her, it, it
Especially
was
if
a
they're
safety
successful
issue.
without it.
Right. Well, exactly. And doing everything else. Like you see people's programs and they may be doing an exercise or not for whatever reason. But when I watch somebody do an exercise, like when I have a home exercise program in mind for whatever patient, I don't give it to them at the end of the treatment. I give them at the beginning. I watch them do it and I figure, okay, well, is there something I need to do to get them to do this by the end of my hour session? Okay.
Mhm.
So when I, especially with her and other patients, I ask, let's just do a lunge. And if I see a hesitancy and it's like it happens like that, I know there's a safety issue.
Yeah. It's
There's
like,
a
why are
few.
you hesitating? What are you worried about? Tell me what's going
Yes.
on.
Yeah. And I have that too with certain movements for me myself as well. So
Mhm.
I think this is great. Thank you, Susan. That was
Yeah.
pretty much it. I mean, it was, we've done a lot in fear. We haven't done a lot, but the most recent one on fear-based movement patterns was, I don't know, maybe about, God, this will be May when this airs, probably about a month or so ago, maybe, I think, or 2 months ago we did one.
Yeah, it wasn't too long ago.
It wasn't too long ago. And, but just, bearing in mind that the title is like going to be, something, with regards to holes in programs, look at your patient exercise programs, see what their drivers are. Is there a hole? Is there a hole in the program? It's a great way to do a chart review. If someone's plateauing, it may not be what you're doing, it may be what you're not doing, right? And so there
Mhm.
could be a hole. Look at the patterns. I think Shirley Sarman once said this some years ago when I took a course. We're looking for clinical patterns. That's what makes us experts, right? So if you see a clinical pattern and see if your patient fits into that pattern, and if there's something that you've missed, add it, right? So there you go.
All
Thanks,
right.
everybody. See you on
Thanks,
the next
everyone.
episode.
Please leave your comments, like and subscribe if you're watching us on YouTube. Otherwise, leave us a review wherever you're listening to this podcast, and we'll see you on the next one.
Bye.